Renal function test. The kidney performs many important functions to regulate the internal environment of the body. It is the main regulator of all the substances of body fluid and responsible for maintaining the hemostasis functions of kidney. The kidney has five functions: urine formation, regulation of fluid and electrolyte balance, regulation of acid-base balance, hormonal functions, excretions of non-protein nitrogenous substances, urine formation, removal of a waste product from the blood, preservations of essentials solute are accomplished through the formation of urine. This process involves urine filtration. This occurs in the glomerulus, which allows water and electrolytes to pass through, but not larger molecules like plasma proteins. These substances are filtered from the glomerulus into the Bowman's capsule and at a rate of 125 milliliter per minute. This is called the glomerulus filtration rate. Selective reabsorption. This takes place in the tubular system, which is divided into proximal convoluted tubules. Here, the reabsorption of glucose and other carbohydrate takes place. Loop of Henle, sodium and water absorption takes place. Distal convoluted tube, where water reabsorption takes place. Secretions, regulations of fluid and electrolyte balance. The water content of the body is 60% of body weight, so the water balance is achieved through the concentration and diluting mechanism of the kidney, which occurs in loop of Henle. A concentrating mechanism becomes effective when human body needs water. The urine analysis increases during this mechanism. The diluting mechanism takes place when there is excessive water in the body. Therefore, the osmolality decreases. Acid-base balance. The kidney is one of the organs among the three systems of that controls acid-base balance. Hormonal action. The kidney acts as a target organ for many hormones like antidiuretic hormones and aldosterone. It acts directly as an endocrine organ, secreting hormone like 125 dihydroxycholecalciferol, renin, prostaglandins, erythropoietin, excretion of NPN products of metabolic urea, creatine, uric acid, or the substances emitted by the kidney. The kidney functions are affected by the following: pre-renal causes, renal causes, and post renal causes. Pre-renal causes: dehydration, diarrhea, shock, and cardiac failure. Renal causes: the disease affects the glomerular filtration rate and tubular functions. Any changes of the renal tubule system which increases the blood flow. Post-renal causes: the obstruction to the urine flow, prostate enlargement and constitutions. Depending on the commitment on the causes for decreased renal functions and renal psychology, the renal functions tests are divided into two groups. Test measuring GFR clearance test, inulin clearance test, urea clearance test, creatinine clearance test. The study of elimination of NPN substances, just measuring the retention of NPN substances is the serum, urea, uric acid, creatine, amino acids, and ammonia. The clearances are the extremely useful, effective, and sensitive way of measuring the actual excretory capacity of the kidney. Clearance is defined as a volume of the plasma completely cleared of substances which is excreted in the urine. Clearance can be calculated as UV divided by dP. The creatinine clearance test, it is performed. It is preferred clearance test used to find out the glomerular filtration rate. It is the volume of plasma completely cleared of creatinine which is excreted in the urine. The creatinine clearance is very convenient to measure GFR because it fulfills all requirement of substances, which is ideal for measuring GFR. In addition to this, amount of the creatinine produced is relatively constant and it is not affected by the dietary intake. Procedure, a minimum of 600 ml of water is given to the patient. The first urine sample is discarded, then start the collection of urine for 24 hours with the preservatives. Starting and ending time of collection are recorded. During this time, the specimen of the blood is also collected. The creatinine clearance, creatinine concentration is determined in the urine and also in the blood. The GFR is influenced by renal blood flow, plasma, colloidal, osmotic pressure, determination of urine creatinine, and calculation of creatinine clearance. The urine creatinine is estimated using the Jaffe method. Urine creatinine level can be used as a screening test to evaluate kidney functions or as a part of creatinine clearance test. Normal value are highly dependent on the age and learned body mass of the person. The urine is being collected from the normal range of varies from laboratory to laboratory. Urine creatinine 24 hour sample values may therefore be quite variable and can range from 500 milligram per day to 2000 milligram per day. GFR measures measurement or indicated acute tubular necrosis, congenital heart disease, dehydration, glomerulonephritis, shock, acute nephrotic syndrome, acute and chronic renal failure. Study of estimation of NPN studies. The intermediate or end product of protein metabolism includes urea, creatinine, uric acid, amino acids, and NH3. Urea is the end product of protein metabolism. The ammonia formed during the amino acid metabolism is toxic to the human body. It should be converted to non-toxic substance and excreted normally. Urea constitutes about 45% of NPN substances. The study of this elimination by simultaneous study of blood and urine may help in understanding the renal distribution. Chemical method: blood urine determination by DAM method, diacetyl monoxide method. The urea test is somewhat a routine test used primarily to evaluate renal kidney functions. The test is often performed on the patient with many different diseases. Urea is formed in the liver as the end product of protein metabolism. During digestion, the protein is broken down into amino acids. The amino acid contains nitrogen, which is removed as ammonia, while the rest of the molecules is used to produce energy or other substances needed by the cell. Ammonia is combined with other intermediate to produce urea. Urea makes its way into the blood and it is ultimately eliminated in the urine by the kidney. Most renal diseases affects urea excretion, so that urea level increases in the blood. The patient with dehydration or bleeding into the stomach and or intestine may also have an abnormal urea level. Numerous drugs also affects urea by competing with it for elimination by kidney. Principle: urea reacts with diacetyl monoxamine under strong acidic condition in presence of ferric ions and thiosemicarbazate to give pink color complex. Upon determination of urea using the standard graph. The direct urea method for urea estimation. The urease enzyme hydrolyzes urea to ammonium carbonate, which on treatment with the NACES reagent produces yellowish orange color. The absorption of the color produced is measured photometrically using the green field or at 540 nanometer. The specimen venous blood is collected with potassium oxalate as a anticoagulant. Yes, enzymatic method: estimation of urea by glutamate dehydration, dehydrogenase. Kinetic method: clinical significance, normal value, serum plasma 8 to 4 milligram per deciliter, 2.49 to 7.47 millimolar per liter. Blood urine nitrogen 7 to 21 milligram per deciliter. Greater than normal value may indicate pre-renal causes, congestive heart disease, myocardial infections, hypovolemia due to the burns, shock or dehydration, excessive protein catabolism, gastrointestinal bleeding. Renal causes: acute glomerulonephritis, chronic nephritis, pyelonephritis, nephrotic syndrome, acute tubular necrosis. Post-renal causes: urinary tract obstruction to urine flow, stone, tumor, enlarged prostate. Lower than the normal level may indicate liver failure, low protein diet, malnutrition and over hydration. Creatine is the breakdown product of creatine, which is important part of muscles. The most important source of energy inside the cell is the ATP molecules, where there's a high energy phosphate bond. When one of these bond is broken, energy is released and ATP becomes ADP. The creatine phosphate represents a backup energy source for ATP because it can quickly reconvert ADP back to ATP. Over time, the creatine molecules gradually degrades to creatine. Creatine is the waste product, that is, it cannot be used by the cell for any constructive purposes. The daily production of creatine and subsequent creatine depends on the muscle mass, which fluctuates little in most normal people over long period. Creatine is excreted from the body entirely by the kidney. When normal kidney functions, the serum creatinine level should remain constant and normal. A measurement of serum creatinine level is used to evaluate kidney functions. The urea creatinine level can be used as a screening test to evaluate kidney functions or as a part of creatinine clearance test. Determination of serum creatinine. The test is performed to evaluate kidney functions. If kidney functions is abnormal, creatinine level will increase it in the blood due to the decreased excretion of creatinine in the urine. Creatinine level also varies according to the person's size and muscle mass. Jaffe's method, Bonsness and Tunsky. The serum creatinine does not increase until urine function is below 50% of normal. Simultaneously, urea nitrogen and creatinine nitrogen determination have more significant clinical significant chance. Principal creatinine is alkaline medium. Creatinine in alkaline conditions reacts with picric acid to form alkaline citrate picrate. The reddish color is formed in the measure of colorimeter to 520 nanometer, and creatinine is determined. Determination of creatinine. Interpretation. The interpretation: normal value 0.8 to 1.4 milligram per deciliter. Normal value ranges may vary slightly among the different laboratories. Higher than normal level may indicate nephrotic syndrome, chronic glomerulonephritis, acute tubular necrosis, dehydration, diabetic nephropathy, reduced renal blood flow, pyelonephritis, renal failure, urinary obstructions. Lower than normal level may indicate muscular dystrophy and myasthenia gravis. Estimation of glomerular filtration rate varies. Different diseases, conditions, and drugs can affect the functions of kidney. The estimation of glomerular filtration rate does not diagnose any kidney diseases, but in a test to assess how well your kidney is working. The estimation glomerular filtration rate is a test that is used to assess how well the kidney are working. The test estimates the volume of the blood that is filtered by your kidney over a given period. The test is called the estimation glomerular filtration rate because the glomeruli are the tiny filters in the kidney. If these filters do not do their job properly, then kidney is said to have reduced or impaired kidney functions. The glomerular filtration rate with the EGFR test involves a blood test which measures creatinine. Creatinine is normally cleared from the blood by the kidney. If kidney are not working properly, the level of creatinine in the blood goes up. The EGFR is then calculated from the age, sex, and blood creatinine level. An adjustment to the calculation is needed for people with African Caribbean origin. Uric acid. It is the end product of purine metabolism. Interpretation: normal value of uric acid is 2.5 to 7 milligram. Higher than normal value may indicate renal failure, acute gout, pneumonia, sepsis, leukemia, polycythemia, anemia. Lower than normal level may indicate acromegaly. Aminoaciduria, the presence of amino acids in the urine. Small amount of amino acids are also present in normal urine. The aminoaciduria test screens for increased level of amino acid excretion in the urine that indicates a possible inborn error metabolism caused by the specific enzyme deficiency. The aminoaciduria may be a primary or secondary. The primary aminoaciduria is due to an inherited enzyme deficiency. This is also called as inborn error of metabolism. The defect is located in the pathway by which amino acid is metabolized or renal tubular system by which amino acid is absorbed. Secondary aminoaciduria may be due to disease of liver or renal tubular dysfunctioning or protein energy malnutrition. In both the conditions, the metabolites of amino acids accumulates in the blood or excreted in the urine. There are several tests to detect these amino acids and the metabolism in the urine. Determination of amino acids. Amino acids are a part of NPN. The determination is helpful only in some congenital renal disorder. If there is a defect in reabsorption, more amino acids may appear in the urine. This condition is called aminoaciduria. For example, cystinuria and homocystinuria. Alkaptonuria is a rare disease that is inherited. The disease results from the deficiency of a enzyme homogenetic acid oxidase. This enzyme deficiency leads to the buildup of homogenistic acid in tissue of the body. It is a classical recessive condition. The gene for it is autosomal chromosomes. The parents of the people persons with alkaptonuria each have one alkaptonuric gene and a normal gene paired with it. The achronosis is a darkening of tissue of a body that is caused by the pigment composed of excess homogenetic acid in patients with alkaptonuria. The pigment accumulates in the cartilage of the joints and ears, skin, whites of eyes. The bluish discoloration of the nail is also characteristic. Alkaptonuria leads to premature progressive degeneration of cartilage of joints due to the accumulation of homogenetic acid in the cartilage. This results in osteoarthritis of joints throughout the body at an unusual early ages. The typical joint effect includes the spine, knee, hip, and shoulder. The joint symptoms includes stiffness, pains, swelling, and limited motions. The homogenesic acid accumulation in the urine will causes it to turn black. The urine from a person with alkaptonuria turns black on standing if it is alkaline. Phenylketonuria. It is an inherited disorder that increases the amount of amino acids phenylalanine to harmful level in the blood due to the defect of phenylalanine hydroxylase. If phenylketonuria is not treated, the excessive phenylalanine can cause mental retardation and other serious health problems. Identification of amino acids. Paper chromatography. When the test shows increased level of amino acids in the urine, a 24-hour quantitative urine chromatography is necessary to accumulate a measure of elevated level of specific amino acids. Metabolic screening. The inborn error of metabolism results in the mental retardation. Several quantitative tests are done on the urine sample to detect excessive excretions of accumulated metabolism. Specimen random urine. Test measuring the tubular functions. Excretory functions test. Phenol sulfonaphthalene test to measure the concentrating and diluting ability. Specific gravity determination, osmolality determination, concentration and diluting mechanism of kidney. 12 hours specific gravity test. The diet is involved in into 3. Take 8 determination of osmolality of urine and serum. The urine osmolality measurement test will be more accurate test to check the concentrating ability of renal tubules. The osmolality is measured of total concentration of dissolved particles in the solution. Normal value serum 275 to 295 molar group. Urine 1400 solution per kilogram of water. Estimation of water dilution test. If the renal function is impaired, the quantity of estimated urine will be very slow. In this condition, increased specific gravity may be seen. Urine test checks different components of urine. A waste product made by the kidney. A regulator urine test may be done to help find the causes of symptoms. The test can be given information about the health and the problems you may have. Urine analysis. The kidney takes out waste materials, minerals, fluid, and other substances from the blood to be passed in the urine. The urine has hundreds of different body waste. More than 100 different tests can be done on urine. A regular urinary analysis often includes the following tests: color. Many things affects urine color, including the fluid balance, diet, medicines, and diseases. How dark or light the color is tell you how much water is in it. Vitamin B supplement can turn urine bright yellow. Some medicines black berries beet or blood in the urine can turn urine red brown. clarity. Urine is normally clear. Bacteria, blood, sperm, crystals, or mucus makes urine look cloudy. Odor. Urine does not smell very strong but has a slightly nutty odor. Some diseases cause changes in odor of the urine. For example, an infection with E. coli can cause a bad odor, while diabetes or starvation can cause a sweety, fruity odor. Specific gravity. This checks the amount of substances in the urine. It also shows how well the kidney balances the amount of water in the urine. The higher the specific gravity, the more solid materials is in the urine. When you drink a lot of fluid, your kidney makes urine with a high amount of water in it, which has a low specific gravity. When you do not drink fluid, your kidney makes urine with a small amount of water in it, which have a high specific gravity. pH. The pH is measured of a high acidic or alkaline in the urine. A urine pH of 4 is strongly acidic, 7 is neutral, and 9 is strongly alkaline. Sometimes pH of the urine is affected by certain treatment. For example, your doctor may instruct you how to keep your urine either acidic or alkaline to prevent some kind of kidney stone from forming. Proteins. Protein is normally not found in urine. Fever, hard exercise, pregnancy, and some the disease, especially kidney disease, may cause protein to be in the urine. Glucose is the type of sugar found in the blood. Normally there is very little or no glucose in the urine. When the blood sugar level is very high, as in uncontrolled diabetes, the sugar spills over into the urine. The glucose can also be found in urine when kidney are damaged or disease. Dipstick employs the glucose oxidation reaction for screening of a specific for glucose, but can miss other reagents sugar such as galactose and fructose. Nitrate. The bacteria that causes a urinary tract infection makes an enzyme that changes urinary nitrate to nitrate. Nitrites in the urine shows UTI is present. Leukocyte esterase. Leukocyte esterase shows leukocytes, white blood cells in the urine. WBC in the urine may mean a UTI is present. Ketone. When the fat is broken down for energy, the body makes substances called ketones. These are passed in the urine. The large amount of ketone in the urine may mean a very serious conditions. Diabetes, ketoacidosis is present. A diet low in sugar and starches, starvations, or serves severe vomiting may also causes ketone to be in the urine. Bilirubin or urobilinogen, unconjugated bilirubin in water insoluble and not normally present in the urine. The conjugated bilirubin only present in the urine in the presence of liver disease or obstruction of a bile duct. A small amount of urobilinogen is normally found in the urine, but a significant amount suggests that further assessment for hemolytic and hepatocellular disease is indicated. A urobilinogen level can be increased in condition associated with the elevated urine level. Microscopic examination. Elimination of elimination of water regulation test. If renal function is impaired, the quantity of estimated urine will be very low. In this condition, increased specific gravity may be seen. A urine test checks different components of urine waste products made by the kidney. A regular urine test may be done to help find the causes of symptoms. The test can give information about your health and problems you may have. Urine analysis. The kidney takes out waste materials, minerals, fluids, and other substances from the blood to be passed in the urine. The urine has hundreds of different body waste. More than 100 different tests can be done on the urine. A regular urine analysis often includes the following test: color. Many things affects urine color, including fluid balances, diet, medicines, and diseases. How dark or light the urine is tell you how much water is in it. The vitamin B supplement can turn urine bright yellow. Some medicines black berries beet or blood in urine can turn urine red brown. Clarity in urine is normally clear. Bacteria, blood, sperm, crystals, or mucus can make the urine like cloudy. Odor. The urine does not smell very strong but has a slightly nutty odor. Some diseases causes changes in odor of the urine. For example, an infection of E. coli can cause a bad odor, while diabetes or starvation can cause a sweety, fruity odor. Specific gravity. This checks the amount of substances in the urine. It also shows how well the urine urine balance the amount of water in the urine. The higher the specific gravity, the more solid materials is in the urine. When you drink a lot of fluid, your kidney makes urine with high amount of water in it, which has a low specific gravity. When you do not drink fluid, your kidney makes urine with a small amount of water in it and have high specific gravity. pH. The pH is measure of how acidic or alkaline the urine is. The urine pH of 4 is strongly acidic, 7 is neutral, and 9 is strongly alkaline. Sometimes the pH of the urine is affected by certain treatment. For example, your doctor may instruct how to keep your urine either acidic or alkaline. Protein is normally not found in urine. Fever, heart exercise, pregnancy, and some diseases, especially kidney diseases, may causes a protein in the urine. Glucose is a type of sugar found in the blood. Normally there is a very little or no glucose in the urine. When blood sugar level is very high or in uncontrolled diabetes, the sugar spills over into the urine. Glucose can also be found in urine when the kidney are damaged or disease. Dipstick employs the glucose oxidase reaction for screening or specific for glucose, but can miss other reducing sugar such as galactose and fructose. For this reason, most newborn and infant urines are routinely screened for reducing sugar by method other than glucose oxidase nitrate. The bacteria that causes urinary tract infection makes an enzyme that changes urine nitrate to nitrate. Nitrate in urine shows a UTI is present. Leukocyte esterase shows leukocytes in urine. WBC in the urine means the as UTI is present. Ketones, when fat is broken down for energy, the body makes substances called ketones. These are processed in the urine. Large amount of ketones in the urine means a very serious conditions. Diabetic ketoacidosis is present. A diet low in sugar and starches, starvations or severe vomiting may also causes ketones to be in the urine. Bilirubin or urobilinogen, unconjugated bilirubin in water, insoluble or not normally present in the urine. The conjugate bilirubin only appears in the urine in presence of liver disease or obstruction of a bile duct. A small amount of urobilinogen is normally found in urine, but a significant amount suggests that further assessment of hemolytic or hepatocellular disease is indicated. Urobilinogen level can increase in conditions associated with elevated nitrate level. Microscopic analysis. In this test, urine is spun in a special machine, so the solid material sediments settle at the bottom. The sediment is spread on the slide and look at under microscope. The things may be seen. Now the slide includes the following: red cells or white cells. Blood cells blood cells are not found in the urine normally. Inflammations, the disease or injury to the kidney, ureter, bladder or urethra can cause blood in the urine. Strenuous exercises such as running a marathon can also cause blood in the urine. White blood cells may be significant of infections or kidney disease. Cause some types of kidney disease can plugs materials called cast to form a tiny tubules in the kidney. The cast then gets flushed out in the urine. The cast can be made of red or white blood cells, the waxy or fatty substances of protein. The type of cast in the urine can be shown. What type of kidney disease may be present. Crystals. Healthy people often may have only a few crystals in the urine. A large number of crystals or certain types of crystals may means kidney stones are present, or there is a problem with how the body is using the food metabolism. Bacteria, yeast and or parasite. There are no bacteria, yeast or parasite in urine normally. If these are present, it can means you have an infection. Squamous cells. The presence of squamous cells may mean that the sample is not as pure as it needed to be. These cells do not mean there is a medical problem. But your doctor may ask you that you give another urine sample. Consequence of chronic renal failure. Chronic kidney disease is also known as a chronic CKD is also known as a chronic renal disease, and it is a progressive loss in renal functions over a period of months or years. The symptoms of worsening kidney functions are unspecific and mean and might include feeling generally unwell and experiencing reduced appetite. Often chronic kidney disease is diagnosed as a result of screening of people known to be risk of kidney problems, such as those those with high blood pressure or diabetes and those with blood relative with chronic kidney disease. The chronic kidney disease may be also be identified when it leads to one of the recognized complications such as cardiovascular disease and anemia or pericarditis. Chronic kidney disease is identified by blood test for creatinine. Higher level of creatinine indicates a lower glomerular filtration rate, and as a result, a decreased capability of a kidney to excrete waste products. The creatinine level may be normal in early stages CKD, and the condition is discovered if urine analysis testing of urine sample shows that the kidney is allowing loss of red cells, loss of protein or red cells into the urine. The CKD chronic kidney disease is initially without specific symptoms and can only be detected as an increase in serum creatinine or protein in urine. As kidney function decreases, blood pressure is increased due to the fluid overload and production of vasoactive hormones created by the kidney via RAS, renin and angiotensin system, increasing one's risk of development hypertension and or suffering from the congestive heart failure. Urea accumulates leading to ozothemia and ultimately uremia. Symptoms ranges from lethargy to pericarditis and encephalopathy. Urea is excreted by sweating and crystallizes on skin. Uremic frost, potassium accumulates in the blood known as hyperkalemia with a range of symptoms including malaise and potentially fatal cardiac arrhythmias. Erythropoietin synthesis is decreased, potentially leading to anemia, which causes fatigue. Fluid volume overload, impaired ability of the kidney to regulate water balance leads to fluid overload or fluid depletion very easily. Symptoms may range from mild edema to life-threatening pulmonary edema. Hyperphosphatemia due to the reduced phosphate excretion. Hypokalemia due to 125 dihydroxy vitamin D3 deficiency. The 125 dihydroxy vitamin D3 deficiency is due to stimulation of fibroblast growth factor 23. Later this progress to the secondary hyperparathyroidism, renal osteodystrophy and vascular calcification that further impairs cardiac functions. Metabolic acidosis due to the accumulation of sulfate, phosphates, uric acid. This may cause altered enzyme activity by excess acid acting on the enzyme and also increases excitability of cardiac and neuronal membrane by promotions of hyperkalemia due to excess acid. As chronic renal failure develops, the ability of the kidney to regenerate bicarbonate and excrete hydrogen ions in the urine becomes impaired. The retention of hydrogen causes metabolic acidosis. The people with chronic kidney disease suffers from accelerated acidosclerosis and are more likely to develop cardiovascular disease than general population. The patient afflicted with chronic kidney disease and cardiovascular disease tends to have a significantly worse prognosis than those suffering only from the latter. Anion gap. In normal serum, there is a balance between the cations sodium, potassium, calcium, magnesium, and anions, chloride, bicarbonate, proteins, organic acid, sulfate, phosphates. This may be varied in renal failures. Pathological conditions of kidney. Acute glomerulonephritis. It is acute inflammation of a glomeruli. There are two types of glomerulonephritis: acute and chronic. The acute form develops suddenly and appears after the infection in throat or in skin. The early symptoms of acute disease are puffiness of face in morning, blood in urine, and urination less than usual. The acute glomerulonephritis is defined as a sudden onset of hematuria, proteinuria, and red blood cells caused. This clinical picture is often accompanied by hypertension, edema, azothema, and renal salt and water retention. Acute glomerulonephritis can be due to primary renal disease or systemic disease. Causes acute glomerulonephritis. In diffuse glomerulonephritis, all the glomeruli are aggressively attacked, leading to acute renal failure. Disorders that attacks several organs and causes diffuse glomerulonephritis are referred to as secondary causes. Secondary causes of diffuse glomerulonephritis includes the following: cryoglobulinuria, globin anemia, Goodpasture syndrome, membrane glomerular basement membrane disease, lupus nephritis, vasculitis, primary disease that solely affects the kidney and causes acute glomerulonephritis, includes the following: immunoglobulin A nephropathy, membrane membranous proliferative nephritis, and post-infection glomerulonephritis. The signs and symptoms of acute glomerulonephritis. The patients who have secondary cause of acute glomerulonephritis often exhibit these symptoms: cough with blood tingled sputum, fever, joint and muscle pain, rash, oliguria, hematuria, proteinuria, anemia, increased blood urea and creatinine. The presence of RBC in the urine insufficient evidence of acute glomerulonephritis because the blood may arises from the urinary tract too. The test that may be done are blood electrolytes, blood urine creatinine, blood creatinine clearance, potassium test, protein in urine, urine analysis. A kidney biopsy will show the inflammation of glomeruli, which may indicate the cause of this condition. The test to find the cause of acute nephritis symptoms may include ANA titer, anti-glomerular basement membrane antibody, anti-neutrophil cytoplasmic body antibody for vasculitis, blood culture, serum complement C3, C4. The chronic form may develop silently over several years. It often leads to complete kidney failure. Early signs and symptoms of the chronic form may include blood or protein in urine, high pressure, swelling of ankle or face, frequent nighttime urination, very blobby or foamy urine. The symptoms of kidney failure include lack of appetite, nausea and vomiting, tiredness, difficulty sleeping, dry and itchy skin, nighttime muscle cramp, nephrotic syndrome. The nephrotic syndrome happens when the urine starts losing large amount of protein in the urine. As kidney get worse, extra fluid and salt build up in the body. This causes swelling, high blood pressure, and high level of cholesterol. The nephrotic syndrome may comes from the kidney disease or from other illnesses such as diabetes and lupus. Increased membrane permeability leads to massive proteinuria. There will be reduced plasma osmotic pressure, and the fluid movement from the vascular to interstitial space that leads to edema. It is characterized by massive proteinuria, edema, hypoalbuminuria, hyperlipidemia, lipiduria. These symptoms has multiple causes. Tubular disease, renal tubular disease. There are variety of disorders of tubular functions, but generalized and specific. These disorders may be isolated defects, generalized tubular defects, as in Fanconi syndrome, or associated with more generalized disease processes. Fanconi syndrome, renal tubular acidosis, glucosuria, nephrogenic diabetes insipidus, phosphate handling disorder, calcium handling disorder, and aminoaciduria. Fanconi syndrome. The Fanconi syndrome is a disturbance of renal tubular functioning resulting in generalized aminoaciduria, phosphaturia, glycosuria, rickets, or osteomalacia. Renal tubular causes acidosis causes inherited primary idiopathic sporadic familia, occurs in absence of any identifiable cause, and most cases are sporadic. Some cases are inherited, but the mode of inheritance appears to be variable. Secondly, the cystinosis and tyrosinemia, Wilson's disease, Lowe syndrome, galactosemia, glycogen storage disorder, and mitochondrial cytopathies. Acquired intrinsic renal disease, acute tubular necrosis, interstitial nephrosis, hypokalemic nephropathy, myeloma, amyloidosis, Sjögren's syndrome, hyperparathyroidism, Kawasaki drugs as cisplatin, ifosfamide, gentamicin, valproate, toxin, glue, sniffing heavy metals. Renal tubular acidosis, type 1, classical distal renal tubular acidosis. Inability to form acid urine in the distal tubule may be inherited as a primary disorder or associated with autoimmune disorder. Without the treatment, it leads to the progressive renal failure. Findings: hyperventilation, muscle weakness, cardiac arrhythmias, renal calculi, recurrent UTI, renal failure. Investigations: hypokalemia, Choleremic metabolic acidosis, urinary pH is above 6, hyperkaluria, treatment acute correction, hypokalemic before acidosis, chronic oral bicarbonate, long-term potassium supplement are usually not required as alkali treatment. The alkali therapy prevents excess urine potassium level. Type 2 renal tubular acidosis may occur in isolation but is more often associated with other tubular defect as a part of Fanconi syndrome. Defective secretions of hydrogen ions bicarbonate reabsorption in the proximal tubule leads to excess of bicarbonate in the urine. Findings: polyuria, polydyspsia, proximal mycopathy, osteomalacia or rickets. Investigation: hypokalemia, hyperchloremic metabolic acidosis. Treatment: high dose of bicarbonate are required but prognosis is good. Type 4 renal tubular acidosis occurs in disease associated with reduced aldosterone activities. Causes includes Addison's disease, inborn error of steroid metabolism, diabetes mellitus, systemic lupus erythematosus, chronic tubulointerstitial disease. Drugs: AC inhibitor, beta blockers, potassium sparing diuretics and mineralocorticoid deficiency. Reduce hydrogen secretion in the distal nephron, causes reduced ammonium excretion. Findings: urinary pH, hyperkalemia, hypochloremic metabolic acidosis. Treatment: fluorocortisone is required if there is acidosis or hyperkalemia. Glycosuria, renal glycosuria occurs when there is a failure of a tubular mechanism to reabsorb the entire filtered load of glucose under the condition of normoglycemia. The isolation form of renal glycosuria is familial with a mixed inherited pattern. Many patients with chronic renal insufficiency of mild to moderate degree exhibit renal glycosuria, usually in combination with other disorder and tubular functions. Nephropathic diabetes insipidus caused by intestinal insensitivity to antidiuretic hormones. It may be primary or secondary to number of causes. Drug or lithium diuretics. Metabolic hypokalemia, hypercalcemia, tubulointestinal disease, partial obstructions, pyelonephritis, cystic diseases, granulomatous disease, sickle cell disease. Presentation: polyuria, hypernatremia, uremia, phosphate handling disorder. These are several types of phosphate transport defect causing hypophosphatemia and inappropriate phosphaturia. The most common form includes hereditary hypophosphatemic rickets, hypophosphatemia with rickets or osteomalacia. The presence with growth retardation and early bone deformities. Does not respond to vitamin D but resists to 1,25 dihydroxy vitamin D, that which may only occurs with functional defect on vitamin D receptors. Treatment is with 1 to 125 dihydroxy vitamin D plus amyloid and thiazidine to reduce calcium reabsorption. X-linked hypophosphatemic rickets. Presentation is with poor growth and rickets is in early childhood. There is a defect in proximal tubular phosphate transport that results in persistent hypophosphatemia and inappropriate phosphaturia. Large doses of oral phosphate supplement are required together with 125 dihydroxy vitamin D. The hypoparathyroidism and pseudohypothyroidism causing reduced renal phosphate excretion. Calcium handling disorder, the relative common disorder causing hypercalciuria and less common hypocalciuria. Idiopathic hypocalciuria, high risk of calcium stone formation with hypercalciuria with normal blood calcium, usually results from calcium hyperabsorption in intestine, with hypercalciuria being of overspill type. Hypercalciuria is treated with the dietary restriction of calcium intake. The thiazide diuretic is used where this fails. Hereditary hypercalciuria, nephrolithiasis, the rare disorder associated with proteinuria, nephrocalcinosis, renal stone, and frequent renal failure. Family hypocalciuric hypercalcemia, an autosomal dominant disorder following a general benign course associated with defective extracellular sensory receptors. The hypocalciuria and hypercalcemia are accompanied by the hypermagnesia magnesemia with the parathyroid hormone level normal range. Amino acidureas. These are varieties of amino acidureas, including the heart up disease, homocystinuria, and cystinuria. Heart up disease is a rare autosomal recessive disorder resulting in malabsorption of dietary tryptophan, a pellagra-like syndrome with photosensitive skin lesions, ataxia, and neuropsychiatric disturbance, and amino aciduria with increased renal clearance of neural amino acids. Tryptophan malabsorption prevents like pellagra, but it is less severe. Treatment is oral nicotinamide. Cystinuria, disorder of intestinal absorption, proximal renal tubular reabsorption of by dibasic amino acids, cysteine, ornithine, arginine, and lysine. The inheritance is autosomal recessive. The parents presence with the renal calculi causing renal calculi, hematuria, urinary obstructions, and secondary pyelonephritis leading to renal failure. Calculi are radio opaque and and cyanide nitroprusside urine test is possible. Treatment includes high fluid intake, urine alkalinization, and bicarbonate, D-penicillinamide, and lysine supplementation. Urinary tract infections. UTI is an infection of urinary tract infection and caused by microbes, organisms too small to be seen without a microscope, including virus, fungi, virus, and bacteria. The bacteria are the most common cause of urinary tract infection. Normally, bacteria that enters the urinary tract are rapidly removed by body before they cause symptoms. However, sometimes bacteria overcomes the body's natural defense and causes infections. An infection in the urethra is called urethritis. A bladder infection is called cystitis. Bacteria may travel up the ureter and to multiply and infects the kidney. The kidney infection is called as a pyelonephritis. The bacterial E. coli causes the vast majority of UTI. The microbes called chlamydia mycoplasma can infect the urethra and reproductive system, but not the bladder. The person will ask to give the clean catch urine sample by washing genital area and collecting a midstream urine of salmon in a container. Diagnosis is made by the presence of more than 1 lakh bacterial colonies per ml of urine.